Hello and welcome back to Obcast. Today we're going to talk about preterm labour. Now, preterm labour is very common. Around 7% of babies are born before 37 weeks, which is what we consider preterm. Now, it's important to remember that the more preterm a baby gets is linked with the degree of morbidity and mortality. And for that reason, we consider less than 32 weeks to be very preterm and less than 28 weeks to be extremely preterm. Now, preterm birth contributes to around 80% of perinatal deaths in Australia. And as we've alluded to, there's a significant amount of morbidity, particularly at lower gestations. Now, the complications of preterm delivery are well known. It includes respiratory distress syndrome, intraventricular hemorrhage, necrotizing enterocolitis, problems with establishing feeding and temperature control and glucose and electrolyte homeostasis, and then long-term neurocognitive issues. So this is a really important topic, and therefore I think it's important that for the non-obstetrically trained we just have a very high index of suspicion. Now, it's all really easy when a woman presents with lower abdominal cramping, but really I think we should consider preterm labour in any woman with some abdominal or flank or back pain, even if it's just doing a more considered history and exam. It's just important that we think about this condition because of its associated morbidity. Now, it's important we talk about differentiating preterm labour from threatened preterm labour, and that's based on a few things that we'll touch on in a moment. Now, just some points around the assessment of someone with suspected preterm labour. We're going to be asking about uterine tightenings, abdominal pain, fetal movements, bleeding or fluid loss vaginally. And the reason is obviously we're trying to establish the diagnosis, but also think about other causes of lower abdominal pain in pregnancy, such as placental abruption or preterm, pre-labour rupture of membranes in the setting of fluid loss. We do a fairly general obstetric exam. Now, it's important, in addition to the things I've mentioned here, to assess for the lie of the baby and the presentation, so that if birth is imminent, some plans can be made to the mode of delivery. But really, in these women, we want a set of vital signs, a urine dip, and then beyond the fetal position and lie that we've discussed, we want to palpate the uterus for about 10 minutes and feel for the frequency and strength of contractions. Some fetal monitoring, such as a cardiotocograph, is very important. Less than 27 weeks, a fetal heart rate is a reasonable alternative. And then speculum exams typically done to assess for cervical change. And this is really where the difference between threatened and preterm labour come in, and that is that preterm labour is regular painful contractions associated with cervical changes. Now, I've mentioned here we can do what's called a fetal fibronectin, and I might just elaborate on that briefly now. Now, this is a product that's released from the cervix in the, as the uterus prepares for labour, and the utility of this in a woman with suspected preterm labour really is in its high negative predictive value. So, if, for example, you're working in a small remote clinic and you have a woman with a similar presentation, and you do a fetal fibronectin which is negative, then you can say with fairly high certainty that in the next 1 to 2 weeks it's extremely unlikely that this woman is going to deliver. Now, there's some caveats to that. It should really only be done sort of under 35 weeks, and it's likely to have a false positive if there's been any recent intercourse, bleeding, speculum examination. Traditionally, when this assay was released, it was purely qualitative, i.e. positive or negative, but more recently it's become a quantitative measure, and levels less than 50 are considered to be negative. The higher the fetal fibronectin level, the higher the likelihood ratio of preterm delivery. But generally, in women with a fetal fibronectin over 50 to 100, they're admitted for management of suspected preterm labour. Now, ultrasounds are usually done in these women, and an alternative to the fetal fibronectin is the cervical length. So we consider a cervical length done transvaginally less than 25 millimeters to be short cervix. And again, similar to the fetal fibronectin, the shorter the cervix, the higher the likelihood ratio of preterm birth. And this is usually a time in which the fetal growth as well as placental function and lical volume is tested. Now, in terms of management principles of preterm labour, there's a few that we'll elaborate on. The first one is corticosteroids. Now, these are typically given to reduce some of the morbidity associated with preterm birth, and the majority of that benefit is within improving fetal lung maturation. So betamethasone is typically used in a dose of 11.4 milligrams intramuscularly that's repeated again at 24 hours. Now, if this isn't available, you can use dexamethasone, usually 12 milligrams intramuscularly, 2 doses, but betamethasone is most commonly used. Tocolysis is almost uniformly done. Now, the most common agent is the calcium channel blocker nifedipine, and that's usually given 20 milligrams orally every 20 minutes for 3 doses, with the goal of stopping uterine activity. Now, from there, it really depends on the degree to which you've stopped the contractions, but you can give further nifedipine, and typically do so for 48 hours at a dose of 20 milligrams 6 or 3 hourly, with a maximum, as you can see there. Again, really just to try and allow the facilitation of 2 doses of corticosteroids. It's then stopped. A point I should have mentioned under corticosteroids is they're really just indicated under 35 weeks. Now, other options for tocolysis include a salbutamol infusion. This is more complicated. Usually a dose between 5 and 40 mics per minute is used, and that's just titrated to clinical effect. There are some side effects with beta mimetics, such as tachycardia, tremors, anxiety, also fetal tachycardia, hypokalemia. And just generally requires a higher degree of monitoring, so it's less commonly used. Terbutaline is another beta mimetic, and indomethacin is a non-steroidal anti-inflammatory that's generally reserved for women with cardiac disease or extremely preterm women who have failed initial tocolysis. But it has its own risks, such as prolonged dosing causing fetal pulmonary hypertension and the risk of effects of the ductus arteriosus, so it's not one that's commonly used. Antibiotics are given for preterm labour, and usually if there's no suspicion of any uterine infection or chorioamnionitis, it's as simple as giving intravenous benzoyl penicillin. And neuroprotection is done in the form of a magnesium sulfate infusion when women are less than 30 weeks, as there's been some randomised control trials showing a reduction in the rate of cerebral palsy and improved motor function in early childhood for these very or extremely preterm infants. It's important to monitor mother and baby, and really that includes both their medical status as well as their psychosocial status. It can be an incredibly stressful time and lead to a prolonged admission with impact on relationships and income, and those things are really underappreciated in preterm deliveries. These women are admitted to hospital and sometimes transferred depending on the gestation of the baby. And a few points on that is it's usually preferable for women to be transferred with the baby in utero, but then there's some caveats whereby if a birth is deemed to be imminent, it's typically preferred to send a neonatal team to the woman as opposed to transfer a lady via either road or aeromedical retrieval if the risk of birth en route or in transit is reasonably high. So that's all I've got to say about preterm labour. I hope that is a reasonably clear summary, and I'll see you next time on Obcast.